Hi, everybody. It is 5 minutes past the hour, and it is my great pleasure to welcome you all to this a very special post-Congress webinar dedicated to antibody-drug conjugates in multiple myeloma. And you may wonder why having a specific webinar focused on this topic. Well, actually, the simple answer is that in the last few weeks, the publication of the results of the so-called DREAM-7 and DREAM-8 trials came as a very good surprise, I would say, and a very nice good news for all of us in the multiple myeloma field, because the first in-class antibody-drug conjugate directed against BCMA in myeloma was belantamab, and it has initially a relatively hectic development. And then we've seen suddenly the publication, the release of the results of, I would say, great results of two major international phase 3 trials. So I think whenever there is something new and exciting, it is our duty to discuss all of these data and their impact on clinical practice. And in order to discuss these trials, I have three panelists, namely Dr. Evangelos Terpos from Greece, who actively participated to these trials, Dr. Rakesh Popat from the UK, who has a tremendous experience using antibody-drug conjugate, and we will be joined in a few minutes by Dr. Mariví Mateos, who has also actively participated into these trials. So my first question is to you, Evangelos, if you can just summarize a bit the results of these trials, and we can start with DREAM-8, for instance, and give us the rationale and the key take-home messages from this trial.
Thank you, Mohamad. Thank you for the kind invitation to be with you and discuss two important trials, I think, and the return of belantamab mafodotin in the clinical trials. So the DREAM-8 is a combination trial of belantamab mafodotin with pomalidomide and dexamethasone, which was compared with the standard of care pomalidomide, bortezomib, and dexamethasone in patients with multiple myeloma who have received at least 1 prior lines of treatment, including lenalidomide. The patients had to have documented progressive disease during or after their most recent therapy. And of course, the patient had not to receive a prior treatment with pomalidomide or anti-BCMA, and they have not to be refractory intolerant to bortezomib. So the randomization was 1-to-1 for belantamab pom-dex versus pom-VD, and the primary endpoint was the progression-free survival and key secondary endpoints, of course, including the overall survival, MRD negativity rates, duration of response, and of course, additional secondary endpoints included the adverse event and the ocular findings, as well as quality of life. More than 300 patients were randomly allocated to receive either bela-pom-dex or pom-VD, and the characteristics of the patients included the majority of the patients to be between 65 to 75 years of age. However, there was 12% of the patients above the age of 75 and 24% in pom-VD, 12% in bela-pom-dex. Regarding high-risk cytogenetics, almost 1/3 of the patients had high-risk cytogenetics, and almost 10% of the patients had extramedullary disease. regarding prior lines of therapy. 53% of the patients had received one prior line of therapy and 35% 2 or 3 prior lines of therapy, although there were approximately 12 to 15% of the patients who had received 4 or more prior lines of therapy. That included lenalidomide in almost all patients in POM-Bela-D, and 80% of those were refractory to lenalidomide. And of course, all patients in POM-VD, and 76% were refractory to lenalidomide. So we had a very good representation of lenalidomide refractory patient. The most important, we had prior anti-CD38 monoclonal antibody. So 23% of the patient in POM-VD had received daratumumab, and 23% of those were refractory to daratumumab, and similar numbers were in the Bela-POM-Dex, 21% refractory to daratumumab. So a good representation also of daratumumab refractory patients. I think that the PFS result is extremely important because we have a hazard ratio of 0.52 in favor of belantamab, pomalidomide, and dexamethasone. And the median for POM-VD was 12.7 months, expected according to the Optimism trial, while this has not been reached for the Bela-POM-Dex, but the 12-month probability of PFS was 71% for Bela-POM-Dex versus 51% for POM-VD. And almost all subgroup analysis, with some exceptions like the presence of extramedullary disease, was in favor of belantamab POM-Dex, including the high-risk cytogenetics with a hazard ratio of 0.57. Before going to lenalidomide refractoriness, I have to mention here that the study design had an important belantamab mafodotin dose. And this is the 2.5 milligram per kilogram given every 4 weeks in the first cycle. But then after the second cycle and onwards, we had 1.9 milligram per kilogram every 4 weeks. So the initial dose of belantamab, it's not every 3 weeks, like if you remember, in triple class refractory, the initial license dose, 2.5 milligram per kilogram every 3 weeks. So here we have 2.5 milligram per kilogram every 4 weeks, but only for the first cycle. And then we had a dramatic reduction to 1.9 milligram per kilogram again every 4 weeks. This is extremely important when we are going to discuss toxicity. Regarding patients who are refractory to lenalidomide and refractory to daratumumab, for the refractory to lenalidomide, Bela-POM-Dex was superior to POM-VD with a hazard ratio of 0.45 for the PFS. And for those who are refractory to daratumumab, the hazard ratio was 0.65 in favor of Bela-POM-Dex. Regarding MRD negativity, you can appreciate that the Bela-POM-Dex patients achieved MRD negativity at the level of 32% versus only 5% for POM-VD. And I believe also that we had an overall survival trend in favor of Bela-POM-Dex with a hazard ratio of 0.77. However, the results, as you can imagine, is not matured yet. It's important to talk about toxicity. As you know, belantamab creates ocular toxicity. And indeed, we had vision blurred in 17% of patients grade 3 or more, dry eye 8% of patients grade 3 or more, foreign body sensation in eye 6% grade 3 or more. In general, we have 43% of patients to have a grade 3 or more ocular adverse events, which of course was not present with POM-VD. The respective number was only 2% of grade 3 and more ocular toxicity. The good things is that the visual acuity changes that could affect the activities of daily living were reversible in most of the patients. The first event resolved to normal baseline, for example, happened in 84% of the patients and improved in 92% of the patients regarding the worsening in the best corrected visual acuity. And more importantly, we have not had a deterioration in the global health status quality of life, while after some months, for example, the 3 months, the Bela-Pom-dex seems to have even better quality of life. And I think that the take-home messages from this trial is that the treatment with Bela-Pom-dex significantly reduced the risk of progression or death with a hazard ratio of 0.52 in patients with relapsed refractory multiple myeloma who had received at least one prior line of therapy, including lenalidomide. The Bela-Pom-dex was associated with an early trend in overall survival also, greater depth of response, including MRD negativity and durability, and benefit in progression-free survival too. The safety and tolerability of Bela-Pom-dex was consistent with the known safety profile of the individual agents, and with the time, as the time goes, and the drug is given at the level of 1.9 milligram per kilogram almost every 8 weeks. That was the dose that the majority received after the first cycles due to toxicity. I think it was very well tolerated. And these results suggest that belantamab in combination with pomalidomide and dexamethasone is a new standard of care for patients with relapsed refractory myeloma who have received one prior line of therapy.
No, thank you, Evangelos, for really very nice, comprehensive analysis. And we will discuss all of these results and their impact. And I've been communicating with Dr. Mateos. She is a little bit stuck in the transport, but we will have to continue because people are connected and we are live now. Rakesh, can I kindly ask you to give us a brief overview about DREAM7, which is slightly different because here the partner is bortezomib, actually, in contrast to DREAM8. And then we will look into the implications of these results, because in DREAM7, the population is completely different, probably less advanced. And the comparator arm is not the PVD, but Dara, bortezomib, Dex from the Castor trial.
Yeah, absolutely. So again, thank you for the kind invitation, Mohamad, and it's a pleasure to do this. And DREAM7 was actually the study that was reported first, and then DREAM8 was reported subsequently. And so DREAM7 was another phase 3 randomized clinical trial, and it was patients from one or more prior lines of therapy were randomized to receive the standard of care, as you say, was the Castor trial regimen, daratumumab, bortezomib, dex, versus belantamab, bortezomib, and dexamethasone. Now, a few things just to point out about the schedule of how these drugs were given. The DVD control arm was given exactly as per Castor. So as you know, the Dara was given weekly initially, then stepping down to 3 weekly, and the bortezomib was given bi-weekly in Castor. And then the bortezomib stops, and then you continue with daratumumab maintenance thereafter. With the Bela-VD cycle, it was matched onto the control arm. So unlike, as Evangelos described, the belantamab being given Q4 in DREAM8, here in DREAM7, the belantamab is given Q3 weekly dosing at a dose of 2.5 throughout. So it doesn't drop down, it continues at 2.5 throughout. And the bortezomib is given bi-weekly and then stops after 8 cycles, and then you just get belantamab maintenance as monotherapy until disease progression. So initially, Mariví presented this, the initial interim analysis last year, and then she updated it at ASCO-EHA again this year. And essentially what we're seeing is, again, a similar substantial improvement in progression-free survival of the Bela-VD compared to the DVD. But this time it's quite remarkable. So the progression-free survival that we're seeing with Bela-VD is in the region of 35 months. 35 to 36 months, compared to about 13 months for the control arm. So almost a tripling of the PFS for the Bela-VD. And when you look at the overall survival, it's still very immature, but there is again a trend towards an improvement in OS. So quite remarkable results, I think, and none of us were particularly expecting such a result for the Bela-VD combination. The toxicity profile is really what you'd expect. Really what we're seeing is keratopathy, which was very common in patients in the Bela-VD. Interestingly, in the Dara-VD, we're also seeing some ocular toxicity. And again, it just tells you that our myeloma patients do suffer from eye side effects, which we tend to ignore, I do believe. But there were some side effects. There was some thrombocytopenia, particularly in the Bela-VD arm, because of the overlapping toxicity of Bela and bortezomib, which we just have to be a little bit careful about. But the infection risk, I think, was fairly similar. And as Evangelos, I think, pointed out, realistically, patients were getting the belantamab every Q8 to Q12 dosing, realistically, as time goes on. Just a quick point about the subgroup analysis that Mariví was able to present at EHA. And what I think is very interesting on that is when you look at the high-risk subgroup, the PFS is almost identical to the main group. It's over 30 months for the high-risk cytogenetics. And I think this is very intriguing because it's suggesting here that Bela-VD might be able to overcome the high-risk profile. Just in terms of caveats on this study, we just have to remember a few things about this. If we just think about when this study was run and the sites where this study was undertaken, there was a low number of patients who had prior daratumumab. So daratumumab refractoriness was an exclusion because the control arm was Bela-VD, and we see just 2% of prior daratumumab across both arms. It was equal, but nevertheless, it was low. And we also see a low proportion of lenalidomide exposure. It's about 30%, so slightly lower than the study that Evangelos described. But again, it was matched across both arms. So we just need to bear this in mind when we contextualize the results. So over back to you, Mohamad, for the discussion.
No, thank you very much. Very sensible and nice summary. And indeed, it looks like DREAM8 is closer to our current practice than DREAM7. But obviously, in both cases, the results were quite, I would say, almost unexpected at this stage. And we will discuss the efficacy and safety. But Evangelos, maybe I would like to step back 1 minute because I'm not sure everybody in the audience has used or is familiar with antibody-drug conjugates, although I must confess this is a pillar of the treatment of cancer, not only in myeloma. We have antibody-drug conjugates in Hodgkin lymphoma, in ALL, in AML, in many solid tumors. Just can you remind us what is the mechanism of action of belantamab and why combination with whether an IMiD or a proteasome inhibitor is something of value?
Thank you, Mohamad. Belantamab mafodotin is a humanized afucosylated anti-BCMA monoclonal antibody conjugated to the microtubule inhibitor monomethyl auristatin F by a protease-resistant cysteine linker. So this means that we have a monoclonal antibody which is conjugated with a drug that is toxic to the specific myeloma cell, the monomethyl auristatin F, which, as I previously mentioned, is an inhibitor of the microtubules. And that's why when it is bound to BCMA in the surface of the myeloma cell, we'll have several actions. One is the direct cytotoxic effectiveness of the drug, but also the indirect through the ADC activity. And I think that this makes the drug to be very effective. Even as monotherapy, you know, in triple-class refractory patient, there was a response rate between 20 and 25%. And that's why it was approved initially in this setting. Now, I believe with the combination of either bortezomib or pomalidomide and dexamethasone give us very good options because we can give the drug at a lower dose and in more prolonged period of time. and this makes it more safe for our patients.
Excellent. Thank you very much. And it looks like, if I want to really summarize it, basically, we have now a smart, fancy way of delivering cytotoxic therapy, which is actually different from the classical immune therapies we debate in myeloma, like CAR T cells or bispecific T cell engagers, which rely actually on the T cell. And this is where the fitness and the immune status is important. Here we are acting independently. So let me ask, so we will discuss the efficacy and the safety, but let me start by the efficacy first, and maybe a pragmatic, practical question. And I would kindly ask our audience to interact. And for those already who posted questions, thank you very much. We'll deal with them. And one colleague mentioned that there are no slides. Yeah, the principle of these roundtable discussions is exactly to do it without slide. We want you guys to concentrate on what the panelists are saying, not watching the slides. You've been able to actually follow the slides in the congresses. So in terms of efficacy, assuming today, Evangelos, standard of care is becoming more and more delivering a quadruplet induction, I don't know, Dara-VRD, Dara-VTD, Dara-VCD, then auto-transplant, LEN maintenance. And assuming, so these are patients who are triple class exposed and becoming refractory to LEN, for instance, and maybe tomorrow we'll give doublet maintenance with daratumumab. So assuming we have access to CAR T cells, to bispecific, and to belantamab, where do you position these different treatment strategies? There may be no single or universal answer, but where do you see the value of using antibody-drug conjugates compared to the other immune therapies, but also maybe other combinations? I don't know, Rakesh, or Evangelos. Evangelos, yes.
Okay. First of all, this is a great question. I think I don't believe that we have one answer to that. It's another thing, as you mentioned, the patients who are eligible for transplant and receive the transplant in a way that you mentioned. Another way, the non-eligible for transplant patients, that the vast majority is receiving the Maya combination of daratumumab with lenalidomide and dexamethasone. And what I mean with that is, in the elderly population, we are going to have more and more patients who are both refractory to daratumumab and lenalidomide. On the other hand, possibly these patients are not, let's say, eligible to receive a CAR T product, or this product may not be available in the countries. Don't forget that we have several countries, even in Europe. I mean, in Greece, we don't have available any of these CAR T products because it's not the country that does not give reimbursement, but the companies, they haven't make the application for reimbursement in Greece. And I think it's the same in many other countries. So for the elderly patients who are receiving lenalidomide and are progressing while on Dara and lenalidomide, you see that we don't have a lot of options. So Bela-Pom-Dex, to my opinion, is a very good option because we have data for lenalidomide refractoriness in almost 80% of the patients, and we have also data for 1/4 of these patients are also refractory or are refractory to daratumumab. So I think that especially for this population, Bela-Pom-Dex probably is the second is the best option for second line. On the other hand, for patients who received a transplant and a quadruplet initially, and then we had the transplant and lenalidomide maintenance, especially if this maintenance is prolonged or the median PFS is very far away from the initial use of the anti-CD38, I believe that there are also other options. Of course, the CAR T for someone which is very young is something that can be taken into consideration if it is available in the country, but also the combination of daratumumab or isatuximab with carfilzomib and dexamethasone is another option, although it has not been studied in a clinical trial for those patients who receive, for example, daratumumab 3 years before or 4 years before. The problem is going to come when daratumumab and lenalidomide are approved according to the Perseus study as maintenance. But this may lead to progressions probably after we are going to have this problem for a minority of patients within the next couple of years, as the expected median PFS for Perseus, it may be more than 10 years. So I think for the elderly, Bela-Pom-dex to me is going to be given after the license as second-line therapy more and more often. For the younger patients, we have other options also, like Dara-Risa with KD, CAR-T, if they are available for someone who is, for example, 55 years of age and progress after quadruplet plus transplant plus lenalidomide maintenance after 2 or 3 years, for example, then probably I would be very keen to offer a CAR-T for this patient.
No, thank you, Evangelos. And I like this algorithm because actually you're not opposing the options, you are just offering different options. And indeed, one classical regimen after failure of Dara-Lendex, like in Maya, is to give PVD. And now we have a regimen which is better than PVD. Then if we follow evidence-based medicine, it should be straightforward. So Rakesh, outside these clinical trials, DREAM7 and DREAM8, you are among the myeloma doctors in the world who have the largest experience, I think, using belantamab. So can you just describe what was the clinical setting you're using it and how does it fit now in your treatment algorithm?
Yeah, thanks, Mohamad. So you're right. We've used a lot of belantamab, and one of the reasons why we use so much is that we got involved right at the very beginning with DREAM1 and the first in human study, and we've found it to be extremely effective and have been using it since. Currently, it is licensed in the UK, although it is not reimbursed, and so we are using it for patients, particularly at 4th and 5th line in the triple class exposed setting as monotherapy. We are hoping to start using it with Bela-VD and Bela-Pom-dex once these licenses come through. But essentially what we're finding is that whilst the response rate for monotherapy is in the region of 30 to 40%, in fact, our real-world data is slightly better than the DREAM2 study. We find a response rate of 40+%, that the duration of the response is very prolonged. It's in the region of 12 to 18 months for patients where you'd expect a durability of response of no more than 6 months. And the key thing here is about the tolerability of the drug and ensuring that we continue to give the drug on a regular basis. So typically what I do is with monotherapy, I give the drug on a Q4 to Q6 dosing. So we do not use the Q3 dosing. This is not a treatment that is tolerable in that manner, namely due to the onset of ocular side effects. This is either symptoms of blurring of vision, gritty eyes and dry eyes, or due to the onset of keratopathy that is found by ophthalmologists. And what I do find is that for those patients who are responding, you can effectively interrupt the treatment and allow these patients to have recovery of their corneal membranes and then allow continual delivery in this fashion. And actually, if you give belantamab on the Q6 or Q8 dosing at 1.8 is actually very tolerable. The other thing that we do is that according to the EU license, ophthalmology assessments are only required for the first 3 doses and are not required thereafter. And it is actually very clear that if you ask a patient proactively about their symptoms, and ourselves, as well as Evangelos, have been developing this questionnaire tool that we initially used retrospectively in DREAM2, and we're now looking prospectively that if you give these patients a questionnaire and we understand what their symptoms are, you can effectively bypass the ophthalmology assessment. And that's hugely progressive and beneficial because not only does it reduce the burden on healthcare systems, but it reduces an additional visit to hospital by the patient. And by simply asking them what their symptoms are within the last 7 days, then actually you can decide whether or not they need belantamab or not. And if you're employing the 1.9 schedule, it's very, very effective. And Evangelos has already shown that you're unlikely to get grade 3 keratopathy in that setting. And we're already doing this in standard of care.
Wonderful. Thank you very much. So we have here a nice comment from Evangelos, and I'll direct it to you, from Dr. Vania Hungria from Brazil. And actually, Dr. Hungria was the first author of the New England Journal of Medicine paper about DREAM7. So congratulations, Vania. And she is our host in Brazil in September for the International Myeloma Society annual meeting. So I greatly encourage everybody to try to join this meeting in Rio de Janeiro. It's going to be a fantastic event. And the question here, because you recommended, Evangelos, the use of belantamab pomdex, like in DREAM8, after failure of a Maya-like regimen, Daryl Index. But these patients were not exposed to bortezomib. So why not Bela-VD, Bela-bortezomib dex? Why would you favor POM?
Great question. Of course, Vania logically asked this question as is the first author, and congratulations from my part also, Vania, for this great success. Definitely Bela-VD is a good combination, but I mentioned about Bela-Pomdex, and possibly I give some hints for this combination compared to Bela-VD, because the study includes more patients who are lenalidomide refractory. So, for example, if I remember correctly, in the DREAM7, it is something like 30% of the patients who are refractory to lenalidomide, while in the DREAM8 is more than 80%. And the second is that, of course, due to the comparator arm, the DREAM7, there was almost no patients who had been refractory to daratumumab in Bela-VD, because, of course, the other arm was Dara-VD, so these patients were excluded, while in Bela-Pomdex study, there were 23 patients, percent of patients who were refractory to daratumumab. So I suggest this regimen only because we have much more patients who were refractory to lenalidomide, and all of them had been exposed to lenalidomide. And second, because we have 1/4 of the patients who were also refractory to daratumumab. This is the only reason. Possibly Bela-VD gives similar results. And if I can say something more for the toxicity, is that I like more the schedule to reduce after the first cycle of the 2.5 milligram per kilogram every 4 weeks, and go directly after a good response, for example, of the first cycle, to go directly to 1.9 milligram per kilogram every 4 weeks, and even every 8 weeks directly, compared to the standard schedule of the 2.5 milligram per kilogram every 3 weeks that the DREAM7 has. I believe that even in this study, I don't know exactly what is the intensity of the belantamab in this study. I assume that definitely it's not the 2.5 milligram per kilogram every 3 weeks. I assume that it's going to be lower, and that's why I like the schedule to reduce from the beginning after the second cycle, instead of starting from the beginning and then reducing the dose. And in addition to what Rakesh mentioned about the ocular toxicity, we have seen also that the 1.9 milligram per kilogram given every 8 weeks, of course, in the newly diagnosed patients, but in my study, all these newly diagnosed patients were intermediate fit or frail, so their median age is around 74 to 75 years of age. And we talk for patients that they had also other ocular problems like cataract, which is very common in that age. I believe that given every 8 weeks, you reduce dramatically what we have seen in the DREAM7 and DREAM8 studies. And I do believe that at least after the first cycles, I mean, the majority of the patients will have belantamab given every 8 weeks or even every 12 weeks. And the very good thing with this drug is that the efficacy is not reduced, even if you give it every 2 or 3 months.
Excellent. Thank you very much, Evangelos. And let me transition now, indeed, to the safety issue, because originally the keratitis and eye toxicity with blurred vision was thought to be a big handicap for using the drug, especially that we know the eye toxicity is something very special, because obviously it can impact your quality of life. But I think what we already heard, that first of all, in these randomized trials, quality of life wasn't altered. And now it appears that, well, we don't need to have like a friend ophthalmologist available 7 days a week, 24 hours a day, although we like the ophthalmologist, by the way, we all have good friends there. And then now it's about this issue of cycle, lengthening the cycle duration, not only reducing the dose. And we end up with something like 3 to 4 infusions per year, which now become a sort of a great added value for many patients. Rakesh, how is it now in your practice? Because at some point you were developing some tools to detect eye toxicity. Do we still need any sophisticated approach to this, or just
no, you're right. So I think there's a couple of things to be said. The problem is that we've all got used to ophthalmology reviews, and to some extent we've become reliant on these ocular reviews to tell us the amount of keratopathy and guiding us whether to not dose the patient. So simply removing ocular assessments, I think, is probably one step too far. Because what we don't want to do is to ruin the confidence of clinicians and patients alike. What we clearly know is that this is a highly effective drug and can be safely delivered, but we need to put these guardrails in to be able to allow this drug to be given all around the world. I mean, just goes back to your earlier question to Evangelos about CAR-T and bispecifics. The clear advantage of belantamab is that it can be given in small hospitals all around the world. And that's really what we need. So what we did in DREAM2 is we did a retrospective analysis on a quality of life questionnaire called the OSDI. And what we found that retrospectively, that if you introduce that questionnaire, then you could effectively be able to dose patients and remove the grade 3 ocular toxicity. Now, moving forward, that's been modulated and tweaked a little bit to a new type of questionnaire. We call it the animastic tool. And we are going to be looking at this prospectively. In fact, in the UK, in my study, we're going to be doing this in a double mask fashion. So patients will have this questionnaire, go and see the ophthalmologist, and we won't be told the ophthalmologist review, and then we'll be dosed accordingly. And the mask will only be broken if we're dosing the patient in an unsafe way. So we'll soon generate some very clear data that I hope prospectively, and Evangelos is doing this in the newly diagnosed setting, we're doing this in the relapse setting, which will show that by using a very simple questionnaire, that patients will not need the ocular assessment. And we can do this very safely. And I think that this will revolutionize the way that belantamab is given. And also to say that you don't get these severe problems anymore. With the 1.9 Q8 dosing schedule, you just get some mild blurring of vision, which is transient, and then it goes away. And we do not see a major impact on the quality of life. So I really think the message needs to go out to clinicians that the way that we now advocating the use of belantamab is completely different to their experience in DREAM2. The 2.5 Q3 dosing should not be given anymore. We should be going to 1.9 Q6 to Q8 dosing. And then what I'm doing now is giving Q12 dosing when patients are stable in remission. And as you say, that's an amazing thing for a patient, just to come up every 3 months to receive a treatment and then disappear. The quality of life is fantastic.
Excellent. Thank you very much. So it looks like, I think this is becoming a sort of a breakthrough addition, I think, to our therapeutic armamentarium. Let's take a couple of questions from the audience. One question, maybe.
May I add something, Mohamad, to what Rakesh mentioned? Because
please.
I think it's important for our doctors to realize that they are not going to see any extreme problems, because like peripheral neuropathy, when we started using bortezomib and we were afraid of that, now also the doctors who deal also with myeloma but with other malignancies also, they may afraid of the ocular toxicity. I can tell them that, as Rakesh mentioned, if you give the 1.9 milligram per kilogram every 8 weeks, which is very effective also, or going every 12 weeks, what we have seen is with that dose, the activities of daily living and this OSDI questionnaire that includes the problems in reading, driving at night, working with a computer or a bank machine, or watching television, which is something important for everybody. These activities for almost or half of the time during the last 2 or 3 days of the questionnaire happened in only 5.7% of the patients, suggesting that all the others, 94% of the patients, will have no problems in these activities of daily living. And I think that this is very important because the median time of reversal of any ocular problem, including sensitivity to light, gritty eyes, painful or sore eyes, blurry vision or poor vision, reverse within 1 month. So when you are going to have the next therapy, which happens in the majority of the cases every 8 weeks or every 2 months, then every problem that you may have has been resolved. And I think that this is a message that the doctors have to know.
No, you're absolutely right. This is an important message. Rakesh?
Just briefly, the infection signal is just worth a comment, because we used to, other than BCMA therapeutics, particularly the bispecifics, of having quite a significant infection signal requiring IVIG in almost all patients. Now we're doing prophylaxis. And we also see infection signal with CAR-T. With belantamab, the infection signal is much, much better. You still get some hypergammaglobulinemia, but in our practice, the IVIG use is much lower. It's about 10%. And we're not seeing those severe grade 3 infections. So again, it just makes it a much more tolerable regimen compared to these other treatments, particularly for those older patients. I think it's very good.
No, it's very important, Rakesh, that you're alluding to this infectious issues. And it's not only about bispecific, it's also about CAR T cells. And yesterday, actually, you may have seen this, there was a Nature Medicine paper from the Sloan Kettering team, and we will probably consider this important paper for an ICH Journal Club in the next few weeks. Looking into all CAR T cells trials in lymphoma, myeloma, and leukemia, and in contrast to our initial concern that the mortality, the non-relapse mortality was related to CRS or ICANS, actually the biggest problem is about infectious complications, especially in multiple myeloma. And the highest rate of infections was observed actually with cilta-cel, then with ide-cel. So I think the infectious complications message is extremely important when looking into these different drugs. And maybe our initial belief may not prove to be true now that hundreds or thousands of patients have been treated. So please stay tuned, because I'm sure we will need to discuss in a journal club this important Nature Medicine paper released yesterday, 8th of July. Let's take the questions from the audience, guys. And Evangelos, one question is about extramedullary disease. So we have a few questions there saying, well, if it is a sort of a strong, potent, smart cytotoxic drug, then do we expect efficacy in extramedullary disease?
As we have seen in every combination, patients with extramedullary disease are doing worse. Even with CAR T cells, with BiTEs, whatever we have, the patients with extramedullary disease are doing worse. It is the same with belantamab, and there are many reasons for that. We have a clever drug, but this does not mean that the myeloma cells are not more clever than we are sometimes, and they reduce or they make a mutation in the area where belantamab can go in order to make it not to be so effective, because it is not bound to the BCMA. So I think that the refractoriness to BCMA immunotherapies in general is a matter of extensive research. And you know very well that people like Nizar Balis from Calgary is doing a lot of work, others from Miami also. I believe that it is something that we don't know very well how to deal with that, and extramedullary disease, due to possible different genomic profile than the standard myeloma cells in the bone marrow, possibly are more refractory to whatever we have. I had a very recent patient of mine who progressed after 3 or 4 prior lines of therapy with a massive plasmacytoma in the thorax. And although we give radiotherapy to reduce it, and then we had CAR T therapy, even with the CAR T therapy targeting BCMA, after CAR T, the PET-CT was worse. than before CAR-T. So even extramedullary disease, many times we don't have a good combo to use. Either CAR-T, there are some results, very good results with alternate talquetamab with teclistamab, which of course has not been licensed yet. So yes, I do agree with our colleague that for extramedullary disease, we don't have a very good combination yet. We improve the efficacy of our drugs, but not at the level that we want.
Thank you very much. We have another question, Rakesh, whether actually, assuming we would like to give CAR T cells, because patients like CAR T cells, they are a single shot treatment, then wait and watch. And I'm aware of many patients who are really enjoying some great quality of life after CAR T cells. The question is, can we use belantamab as a bridge to CAR T cells? Is there any experience or any thoughts about this?
Yeah, it's an interesting question, and I'm not aware of any data to support that. One of the things we just have to be mindful about is with belantamab monotherapy, for example, the response rate is 30%. So that may not be the optimal bridge when you have a response rate like that. So, I mean, some people are looking at talquetamab as a bridge, because it offers a different antigen approach. And of course, the response rate is double that of belantamab. I guess the question is, now that we have some data with Bela-Pom-Dex and Bela-VD, whether or not you could use a triplet as a bridge. And I think that might well be possible. Previously, we've been concerned that if you give a BCMA-targeted agent as a bridge, then you might reduce the antigen stimulation, which may not provoke enough CAR-T expansion. But what was interesting at EHA was the data from CARTITUDE-2, which looked at cilta-cel for patients who failed to achieve a CR post-transplant. So these were patients who had quite a low residual disease, but actually you saw quite robust CAR-T expansion. So it might be possible you might be able to give one cycle of belantamab VD or belantamab Pom-Dex as a bridge for these patients. I think is entirely plausible. And you just have to weigh off that compared to maybe talquetamab as the alternative option. So yeah, I think it's possible, as a bridge.
Excellent. Thank you very much. Evangelos, you wanted to add something?
I think that one of the most important issues here is the sequencing to me. We have seen in the triple-class refractory setting that giving a CAR-T cell after belantamab reduces dramatically the CAR-T cell effectiveness. For example, for the cilta-cel, outside of the 33, 34 months of median PFS that we have in triple-class refractory patients, if you have given an ADC before, like belantamab, this goes directly down to 9 months. So I think that the major question will be what we will give first because of the efficacy of the agent after. Of course, we don't know if this happens in early lines of therapy. This is a matter of investigation, but definitely I do believe that let's say the sequence is extremely important. For me, I would rather give in younger patients a CAR-T before belantamab, for example. But as I previously mentioned, for someone who is an elderly, received the Maya regimen and then progress, and possibly is not, let's say, eligible for a CAR-T product for many reasons, for the age, for frailty, comorbidities, and all these things, definitely belantamab combinations will be my favorite. But we have to be sure about what we are going to give, especially if we don't have both available. For example, there are countries that possibly belantamab may be available and not the CAR-Ts. And we have to think if we have a young patient, what to give first. I think this is a critical question.
No, thank you very much, Evangelos, for raising this. And indeed, this is work in progress, but you're absolutely right to highlight it. We'll take one last question, and it's going to be to you, Rakesh. Based now on DREAM7, DREAM8 experience, based on the previous and real-world evidence data we have about belantamab, what would be your SOP for those colleagues who are going to prescribe and use belantamab for the first time? Which dosage, which schedule, what kind of cautionary measures should be adopted?
Yeah, no, that's an excellent question, and I agree. You have to pull all of this together. So first of all, I think you need to personalize this according to how aggressive the relapse is. If you have a more indolent relapse, then my recommendation is to give belantamab at 1.9 Q8 to begin with, and then once you've achieved a remission, you can step that down to belantamab Q12. Now, if you have a patient with a more aggressive type of relapse, then I think starting off at a 2.5 one-off dose, I think is good. You will have more disease activity and maybe link up some of that soluble BCMA, which will be at high levels for those more aggressive relapses. And then you ought to step straight down to 1.9 as per DREAM8 and deliver that on a Q8 basis. Again, when you're achieving complete remission, then you step back to Q12 and then you'll do extremely well. You'll know whether your patient is responding quite early on or not. Clearly, if they're not responding, then you pull the patient out. So that would be my recommendation.
Wonderful. Thank you so much, Rakesh. We went a little bit beyond our scheduled time, but this was really a fascinating discussion. And in multiple myeloma, and until we have cured every single patient, I think we need to continue working and develop new agents. And the DREAM7 and DREAM8 trial rejuvenated, I would say, belantamab, and this is a most welcome addition actually to the treatment landscape, and I'm sure many patients will benefit from belantamab, similar to the other available agent. So thanks to the whole teams who really worked hard to make it happen and were very perseverant, actually. For the time being, I would like to thank you all for attending, for following the ICH Roundtable Post-Congress webinar. I do apologize on behalf of Dr. Mateos, who was stuck in transport. She's been communicating with me by SMS, unfortunately. But I think Rakesh and Evangelos did a fantastic job. And we were under the supervision of Dr. Hungria, who was watching us from Brazil. A big hello to all our Brazilian colleagues. The ICH activities in relation with myeloma will continue today. We have, if you are a French-speaking patient, family, doctor, we do have a special broadcast at 5 p.m. Paris, Berlin, Madrid time today with the Myeloma Patient Association, the French Myeloma Patient Association, on summarizing the novel data to patient and families. So wherever you are, please stay safe and keep well, and please enjoy a nice summer break if this is going to happen very soon. Thank you very much.
Thank you.
Thank you.